community of practice. Thank you so much. Let me go ahead and begin to share my screen. I am Naomi Williams. I am joining you from what was Muskogee land. I am joining you from Augusta, Georgia today. Let me put this in presentation mode. We are so excited for our community of practice and our presenters today. Naomi is tech challenge this afternoon. We are recording and we will have it on our PFCC Partners YouTube channel. There will be the live transcript there. If you have not already subscribed to our channel, please do so. You can also enable closed captioning on the screen below. For those who are new to PFCC Partners, this is just a quick glimpse into our mission, our vision, and our values. This is what PFCC Partners is all about. We want to see a health system transformed into one that works for people and through the communities as partners in their well-being. We know that healthcare is complex, it's difficult to navigate the systems, and it's even more difficult to impact or have that change. We at PFCC Partners believe that when a system is centers the care and the care processes on that person's behalf, there's potential to reduce that complexity as well as to advance a culturally humble and equitable health system. PFCC Partners opens this space within systems to patients and family caregivers to drive those improvements. We know that patient and family caregiver voices are the catalyst for the improving these healthcare systems and for the systems change. The PFA network, if you're not familiar, I think Lindsay is going to drop the link into the chat for me. But one of the ways that we open this space is through our PFA network. The PFA network is a community that was developed by patient and family members for patient and family members to influence healthcare improvement. So again, the PFA network fills this space with impactful people, stories, and insights. It's through individuals with lived experience. And the way that happens is through community. We have our community forums. We have engagement opportunities, as well as a skills exchange development. So without further ado, it is my privilege to introduce our presenters today who will be speaking on prioritizing research, inclusion, diversity, and engagement, which is PRIDE, so people with intellectual and developmental disabilities community engaged through a community engaged approach. And I will tell you, shameless transparency, when I initially heard PRIDE, my mind initially went to the LGBTQI+ community. So when we learned we were working with the project was actually dealing with people with intellectual and developmental disabilities. It's like, oh, well, let's see where this goes. So I'm excited to introduce Mitchell and Jessica. They can do a much better job, but I'll just do really quick and sharing a little bit about their bio. Jessica Baker currently resides in Tucker, Georgia. She is a proud mother of 4 children, of which 2 have disabilities. Jessica works for the DeKalb County School District in Stone Mountain. She is actively involved with her community, serving on the executive board for her children's PTSA, as well as doing various community service within her sorority and church. Jessica's favorite quote is, "What lies behind us and what lies before us are tiny matters compared to what lies within us." Ralph Waldo Emerson. Thank you for that quote. And then Mitchell Blunt is an experienced public health epidemiologist, researcher, capacity building, and technical assistance provider and project administrator with more than 15 years of experience working with public and health practitioners at multiple levels of the public health sector, including community-based organizations, state and federal government, and institutions of higher education. There's a lot more here about Mitchell, but I don't want to spend our time reading your bio. I want you to go ahead and dive into what it is that you have to share with us. Let me stop sharing my screen so you can go ahead and share yours. Mitchell?
Thank you so much for those wonderful introductions. And it's just amazing to be here with everyone. As Naomi said, Jessica and I are just happy to be able to share some of our work, and then really just to have some conversation with the group. So when we do share, you'll see we have a number of slides. We will not go through all of them. We will share what we believe is most relevant to the group, and then we will make sure they are available to you all. So Naomi, if you can enable sharing. I'm not able to share my screen. Awesome, thank you. Okay. And everybody can see my screen, okay? I always like to do a quality check. Awesome, thank you. And so again, we will be talking about our PRIDE program. And just some of the goals that we're going to showcase some of the findings of our listening sessions that we had with people with disabilities, intellectual and developmental disabilities, family members and caregivers, which is very relevant to this group today, and talk about some of those things that help them to actually engage in research. We're going to describe some of those ways that engagement was successful, especially through our PRIDE program. And then we're just going to highlight some important things that people with disabilities, their families and caregivers should be prioritizing when looking for research opportunities. So just a little background, I will not be able to go back to work if I do not highlight Morehouse School of Medicine, but I will say that we are here located in Atlanta, Georgia. We are one of now 5 historically Black medical schools and institutions, and we are leading the creation and advancement of health equity. And as you can see, I want to highlight our wonderful president, Dr. Valerie Montgomery Rice, here in that left picture, with some of our wonderful medical students. And I operate out of the National Center for Primary Care, which is the only first congressionally designated institute focusing on primary care and health equity. Within the National Center for Primary Care, I operate out of the Research and Policy Division, where we are focused on promoting policies and practices that strengthen and advance health equity. And we really focus on enabling and helping to educate and train clinicians, patients, and communities. And we do that through community engagement activities, which our project is really focused on, and then translating that research and that engagement into policy and policy action. So we'll highlight the previous work that led into what we'll talk about today. And so we actually were able to work on a project, one-year project focused on enabling and addressing and assessing the use of telehealth and other virtual services for people with disabilities in Georgia. And so we conducted a number of surveys and focus groups with people with disabilities, their family members and caregivers as well. And really found that through these surveys, there was a lot of satisfaction with using telehealth during the pandemic, but also there were some barriers and some needs for improvement. And so highlighted digital literacy was definitely an important marker or takeaway from this study, this project, and the need for improved telehealth policy to enable more people with disabilities and their caregivers to access the care that they need. So we use really that information to leverage and drive what we were addressing in our now project that we're working on. So which really leads us to today. So we were funded through the Patient Centered Outcomes Institute, or PCORI, really to engage and build capacity for people with IDD, so intellectual and developmental disabilities, to engage in research, and primarily within our practice-based research network and in Georgia. And so we conducted a number of listening sessions with people with IDD, family members, and direct support professionals. And we're really happy to report that at the time we had completed up to 6 listening sessions, and we were writing up those findings. And so we will share some of those findings here in a moment. So, but some of those objectives really were to address health equity and improve health outcomes for people with IDD, and then create this roadmap or curriculum to be able to empower and equip people with IDD to engage as partners in research, and also to create a advisory board that would lead these activities, which Jessica will help me talk about in just a moment. I just want to shout out some of our partners. We definitely had a lot of engagement with both our practice at the academic and research institution level. So our partners at the Ostero Lab and Metro Health, but also working with the Georgia State University Center for Leadership and Disabilities. So we are very happy and excited to continue those partnerships with them, and then our partnership with the Augusta University and New Hampshire Institute on Developmental Disabilities. So in developing this program, we really wanted to make sure that we were bringing together those subject matter experts and also people with lived experience to really drive all of the activities that we were utilizing for this project and its success. So we really established 2 committees or boards. One was a curriculum development committee, and these were members who maybe have already had experience conducting research or had an interest in conducting research and focused on people with disabilities and their families. And so their main role was to really integrate and adapt existing tools or resources to develop some toolkits and curricula that was really focused on people with disabilities. And then our advisory board, their main role was really to review the listening sessions, which we'll talk about in a moment, and really identify the priority needs that we should address in our PRIDE program. And they oversaw the implementation from start to finish of the program. They were instrumental in developing our sustainability plan and our outreach plan. So who are the partners? Who are the populations? What are the resources that we need? And then, everyone loves to be able to be compensated. And so we make sure that we did compensate our advisory board for their time and their effort. And so I just want to pause here and give way to Jessica for her to just talk a little bit about her experience as an advisory board member, and then we'll start again in a second. So Jessica. So I cannot hear you, and so
I think a couple of us have gremlins in our tech today.
it's just one of those days. And so, while we'll continue to press forward, and then we'll when she's able, give her an opportunity to talk. But let's just dive into some of what we heard from our partners. And so we conducted those listening sessions, and we had a total of 26 participants participate in these listening sessions. And so we asked them questions about how were they able to access different research opportunities, what type of research opportunities were available to them, and then really asked about their actual status. So if they identified as a person with a disability, race, gender, etc. And so as you can see, all of them were residents of Georgia. 11% lived actually in a rural area. So that was very interesting to see. The majority identified as a person with a disability, and the majority participants were male. And so that is very different from our usual research activities where it's predominantly female. So we're really excited to actually see that engagement. And almost half were Black or African or African American, which is also a good highlight and something we were excited to see, because that is generally not what we have seen in our participant demographics and other research. So again, just most participants reported that this was their first time participating in any type of research project. And a little over 30% actually participated in research before. And that participation varied from being participating in like a small survey, maybe it was an ad that popped up about your experience on Netflix, or those Google ads or Google surveys. Maybe it was something that your provider asked you, short survey they asked you to take, to even larger or multiple year federal clinical trials. So we had a couple participants who said they were currently in a clinical trial. So a vast array of experience. We had some that said they actually had advised or were conducting their own research studies. And then a little over 5% who have actually assisted someone with a disability to participate in their research. So some of the things that really helped engagement in research for these individuals was effective communication and advertising. So we really heard that these communication was key, and it is key to really promoting accessibility for people with disabilities and their support persons to participate, and that these communication and advertising must be tailored for people with disabilities. It's really important to know for them how they are helping to attain the goal of the research. So we really heard that oftentimes research institutions or other people will come in and really study these populations, but never really give back or return that information to them. So it's really important for them to understand their impact and how they can help. They really wanted to know how many people did they reach, and what can we tell them or help support them to get more people involved. And they want to know the preliminary results as they go along. They just don't want to know the final thing. And it makes them, again, feel more helpful. So there was a sense of helpfulness that they wanted to partake in. Some barriers, time. It was really highlighted that some research projects and studies just required too much of their time. They had other priorities, and that although there was a need and a desire, it really conflicted with the priorities that they wanted to or needed to live their daily lives. So what was the reputation of the organization? And so it was very important for them to know whether or not the individuals that participated were going to be kept safe. Confidentiality was highlighted a lot, and really making sure that we maintain on their privacy. And even as we have experienced already today, some issues with technology and bandwidth, again, for especially our participants that are in those rural areas where bandwidth is a problem, access to technology and access to transportation, even to get to in-person studies or clinical trials is really was a barrier for them to engage in research. Incentives. So what helped them to engage in research was one quote, one participant said, "If you pay me, I will be there." So, incentivizing um, monetarily, but then again, as was highlighted, the sense of need. We heard from participants that, as you can see at the bottom, is the building that community. And so, particularly in the course of the COVID-19 pandemic, and the height of it, of course, people with disabilities and support persons were really isolated during that time. And so they now and want to use even research opportunities to really build a community. And so it was an opportunity for them to socialize and learn from others. And so this led us, we took all of that information and really developed this now program around and tailored that program with a cohort of 8 individuals. And so 8 individuals with IDD, family members, or direct support professionals to really learn from these experiences, and then for us to train them and support them to really promote, engage in, or advise research activities going forward. So really the goal of the project, again, was to build that capacity. And so we had individuals from various backgrounds. As you can see, the majority were people with a disability. We had one family member participate, some direct support professionals, and some parents as well. And a good range of age range, with primarily the majority of participants being over 50 years old. So we convened our first session in January of 2023, and the PRIDE program actually learning sessions ended in July 2023. So which was a total of 6 months. So during this period, we engaged participants in 4 different learning modules. Each was led by a different facilitator. So to have different experiences. Some were actually individuals with IDD as well. So making sure we engaged, had that peer-to-peer learning. Each of our participants was giving a pre and post-course knowledge survey to participate. And then throughout the longevity of the program, we would do some individual and one-on-one engagement with them as well. So we're just going to highlight some of the results from the PRIDE program. And so one of the questions we wanted to make sure that and concepts people understood was universal design for learning. And so really at the foundation was, are we communicating what we really are saying or want to say to these populations? Is it clear? Is it accessible? And so that was one thing that we actually measured as well. And so we asked them questions that relate to engagement and what they look for on a personal level. And as we can see, prior to the cohort, the program starting, only 25% had engaged in a research study before. And some of those interviews were with clinicians or other researchers about the care that they can receive. And then really talking about and asking how they can serve as advisors to different projects or studies. So we again asked them if they understood their role in participating in this program. Um, some of them did not, and we learned that we needed to do a better job. So we needed to implement that universal design for learning as we went. So there were these constant check-in points with our participants. And so just comparing some of the information that we received. So happy to report that before the presentation for Universal Design for Learning, many of the participants did not or neutral or did not understand what the project was about. And by the end of the session, they did. So we were able to report that we were successful in that. Let's skip to our next session. And so we really wanted to measure how we were really applying the knowledge that individuals were receiving with regards to engaging in research. And so we asked participants before the presentation, before this session, did they understand what research was? And they were able to list out what they felt research entailed. And the majority did, think, but there were still some that were more or less likely to really engage in any type of research due to barriers that we have forementioned before. So whether it was having the proper tools to be able to engage with the provider or being able to have access to the necessary transportation. We asked them, had they felt engaged in our process, in our project? And thankfully, 100%, all of them said they did. And they also felt that the information that we were presenting to them was relevant to help them and make an impact for them to engage in research. And again, just measuring whether or not we were successful in using those universal design for learning principles, and all of them agreed or strongly agreed that we had been doing that. And so we really wanted to, again, on a deeper level, dive into some of the barriers for engaging in research. And as you can see, the majority noted that all of the barriers that we had listed, they had experienced at some point. So with many of them being transportation, proper accommodations, the language that was being used, not understanding the consent, and then again, just time. And I would also like to, I think we have Jessica back, but even as herself as a parent, if she wants to highlight any of these that maybe she has experienced as well.
Yes, hopefully you guys can hear me now. I do apologize. And so, yes, like Mitchell was explaining, I am a parent of two children with disabilities, one with an IDD, another with physical disabilities. And so, for myself, I have actually experienced some barriers with research because of transportation. Well, transportation, not so much. Time, yes. Accommodations, yes. Because of the special needs that would need to be provided for my children, not for myself, but for my children. Um, Time wise, sometimes it did take away from school, work, or other obligations I might have had. I had to rearrange things in order to ensure that their participation or research was able to actually take place. My daughter actually is the one child that has IDD, an intellectual disability, and she actually participated in a research when she was younger. But it did take time because I had to actually take her to the facility in order to participate in the research. And so in that retrospect, I can understand as far as the participants when they say that some of these things do cause barriers. And then on the opposite end, being on the advisory board, understanding when we are putting together that research project, we have to take a look at how can we prevent these barriers from occurring. We can't necessarily stop at 100%, but what is a way to prevent it as much as possible so we can get that 100% participation throughout the entire research project?
Thank you, Jessica, for those insights. And so, really taking into account that as we were actually continuing to go through our project, hearing those accounts from our advisory board members, we had some of their children and some of their actual, for some, the people they were actually providing care to give us some testimonials as well. So it was really impactful for us and really drove how we were developing the rest of the program. I want to kind of go through this last kind of section and then talk about how we are now working to implement or disseminate, share some of this, and how the impatience and implications and resources for other family members to be able to get engaged in research. So thankfully, by the end of the program, we found that there was an increased knowledge for our participants around understanding their role and autonomy and the ethics for engaging in research. And that, the work that we actually were able to do with them helps to support them. Again, they continue to feel engaged, and some of the things that continue to help them was helping this open discussion, having open dialogue, having some visual aids. So the PowerPoint slides really helped them throughout the sessions. And then again, they felt that this would continue to have an impact on their engagement in future research activities. So we did all of that work. We had all of those conversations. And so what we have now done, and some of our takeaways and what we heard was that anyone can engage in research and become a partner on a research team. We heard that throughout the process. One of the barriers that we as researchers were having was making sure that we have the appropriate tools and language to be able to make sure that it's accessible to everyone. And at the end, for all the participants to be able to say that we did that in a meaningful, impactful way was really impactful for us. And so knowing that we can now utilize this curriculum and tool to help other institutions, other organizations, and to really embed in pride this inclusion and diversity and engagement tool with them will help many others. What we learned is that people with IDD want to engage in research and they want to be research partners, but we have to be more inclusive in the way that we design these materials and how we recruit. I don't know, Jessica, if you want to even talk about how the recruitment process was for you, even us reaching out to you, your experience there.
Sure. So as far as the recruitment, and I participate in research projects as well outside of the ones related to IDD. Um, I have no idea how people recruit me. I just know my list. My name is out there somewhere. But what I will say is with this, it is looking at the network of who we already have or who we may know um, that may qualify for what we're looking for. Um, and I think a part of that also is determining how we want to actually, or how you want to, what group that you're looking for. Is it based, do we want a wide range of age, or do we want to actually keep it contained within a certain group? And so that makes a big difference when it comes to what are you really wanting to gain out of the actual research itself. I know for me, I was recruited from an out kind of background, mother, child with disabilities, turning into a mother advocate for my children because they can't speak up for themselves quite yet. And then joining an advisory board. So for me, it's been a stepping stone along the way. But that's because I put myself out there. But like I said, also, my name is out there because I've checked the box to say, hey, I'm interested in helping out with research, in helping out with looking at the bigger picture and how can my experience help somebody else in the future. And I think that's a big thing is creating that that list, the listing of who's interested in assisting with research.
Thank you for that, Jessica. And so where we are moving to next, even to Jessica's point, is we are going to take this information and continue to connect to both our participants and then our existing networks to help connect them with other research opportunities, and then be able to really replicate this model within other research spaces so they can be more inclusive of people with IDD and their support persons in research. And just want to give a quick thank you to our advisory board, who were very instrumental in our research, our wonderful curriculum development committee. And so just to end, as Jessica was saying, that, how can people get involved? Continue to seek out opportunities. We have a number of different projects that are underway, both at Morehouse School of Medicine, at some of our sister organizations. So whether it's an actual continuing education for providers, so for people with IDD to connect their providers to research, heard that they want to be able to do that for their providers as well. And also learning opportunities for people with disabilities and their support persons. So one of our wonderful partners and advisory board members is having a session on personal planning for people with disabilities and support persons and caregivers. So you have that opportunity as well. And then we here at in the NCPC, we have a research meeting that's every second Tuesday of each month. And so that's really to foster that collaboration, both with the research community, but also with our people, our other populations of focus. And so I'll just end here. Of course, we will take questions now, but feel free to contact me, and we continue to love and support the work that we're doing. So thank you so much.
Oh, thank you, Mitchell and Jessica, so much for this rich information. And let me just back up for a quick minute, when I was doing the introduction, when I said about pride and what I initially thought it was, I don't want you all to think that I didn't know what Mitchell and Jessica were coming to actually talk about today, because we have had conversations. So I just want to clarify that. We do have a couple of questions that came in before on the registration, and then a couple in the chat. So Lori asked, how do we help people understand the value of creating this type of inclusion in research to encourage participation?
That is a great question. So I'm going to come from the kind of research hat world, and I definitely welcome Jessica as well. For me, and especially researchers at these institutions, it's understanding that we're talking to the people who are the subject matter experts, right? So getting the lived experience, making sure that we are connecting with those individuals, they know what's best for them. It's hard for me. I can't tell someone with a learning disability how to best live or access resources if I don't hear what they need, right? So it's really honing in on that. And then making sure to understand and lead with empathy. I know sometimes that was one of the things we heard from individuals as well, was that sometimes in the research community, we can be hard within, and so just really first leading with humanity. I hope that answered your question.
And I will just echo what Mitchell stated. Making people feel like they matter and really meaning it. Because like I said, coming from a support person or a family member to have to, or caregiver really, of a person within different disability categories, we know what it is that we experience. And because we have that experience, it's kind of like, hey, we really want to know what your experience is. We really want to know how you really feel, what's really going on. So that way we can take that subject matter and expand it to help others outside of just yourself.
Thank you for that. Can you speak to the universal design? I don't know. So we have a mixed group on here from administrators, researchers, patient family advisors. So we have a mixed group, and looking at for when you talk about research and hospital administration and working to bring in those subject matter experts, you know, the individuals with lived experience. Can you speak to universal design and what that really looked like? How did you do that? What did that look like?
So I will place the caveat that I am not the subject matter expert on the UDL. So I will say that so our partners at the Center for Leadership and Disability have really partnered with us to really lay that foundation for the UDL. So I will give you the definition that they gave us. And so really at its core is really making sure that we are developing different goals, materials, for our administrators, is making sure that we have the appropriate paperwork and protocols in place for our researchers, the correct design of the survey and the project or whatever it is, that it works for everyone so that it is accessible for everyone. But sometimes that means we have to be flexible. And so universal design for learning really is coming in, being open. So even if it's just you've already designed something, and then hearing from your populations of focus and being able to really tailor fit it for that particular population. So there are times where you're going to have to customize it for the needs of other populations. other people, but being able to make sure that it fits for all. And so I will say that even in the midst of our program, that we did tailor our redo our engagement approach. So we were so used as researchers to send out emails, send out emails, send out email blasts, and that did not work for all of the people in the populations that we were serving. So that meant picking up picking up the phone and making a call, walking through the consent forms individually with some people as needed, making sure that we had the appropriate screen readers in place. So in totality, that's what you need to get first.
That's helpful. And y'all, if you all have additional questions, please drop them in the chat or raise your hand. They can come off mute. I'm going to go through a few other ones that we received until I see someone here. So thinking, you mentioned about your demographics, and it was a lot of male and self advocates. So Mitchell and Jessica, so Jessica, you shared kind of how you got here, but one of the things that we have heard a lot from our partners in the healthcare system is how do we reach what seem to be hard populations to engage with? But considering you had 11% from rural community and you had men and self-advocates, so how did you do this? What was the outreach? And then Jessica, from your perspective, why was it important for you to be involved based off of even with the constraints that you have?
So I'll start. And so for us, I will say the beauty and the privilege that we did have is that we had existing partnerships, particularly with Georgia State University and their Center for Leadership and Disabilities. And so, we leveraged that network. So we were able to implement, disseminate and recruit through their networks. If you remember our previous work, so even before this project that we were focused on today, we did a short study with the Georgia Council for Developmental Disabilities. And so really it's utilizing that network and then also allowing your partners to tell you how to effectively make that outreach. I would say sometimes, again, I'll get on us as researchers. We feel like we know best. And so we have to allow the people who do have that collaboration and those relationships already established to tell us and lead us and guide us. And so I would say to help utilize some of those kind of strategies in your outreach. And then I'll turn it over to Jessica.
Okay. And so for me, I found it to be important to kind of be a part of it because, first of all, like presented in the slides, it was a reputable organization. I know Morehouse School of Medicine. I know that they do research. I know that what they are looking for in regards to that research is going to be something that is going to be used nationally, if not even worldwide, because of the name that it already holds to itself, by itself. Another thing is because of my experience with research, like I stated, my daughter, who has an IDD, she did a study back when she was, I think she was like 4 or 5. She was diagnosed when she was 2. But they actually followed up years later to tell me what that research did in regards to projections for things that would be utilized later on in the future for other families and for other individuals going through the same thing that she had as far as early intervention was concerned. And so knowing that as a reputable organization, Um, and then having that follow-up years later, they tracked me down, sent me something in the mail to say, oh, I can read what the study actually did and how it was implemented later on. So what I stated didn't go in vain, like it actually mattered and it was used for other people. And so to me, that makes a big difference in regards to whether I'm gonna be a part of something or not.
And I would just add on, saw the tail end of Lindsay's question and comment as well. So what I will say is that some of what we can attribute to the engagement with males is that they saw males actually in the research. And so part of our partnership, a big part of our team at CLD, excuse me, is have men. And so when we were recruiting, it was sometimes them actually making the phone calls. It was their faces and voices in the materials that we just disseminated. So that makes a difference.
Awesome. Thank you for that. And that just goes to show through all of this, representation matters. You talked about the feedback, close the communication loop. Individuals want to know. Jessica, you spoke to that from an earlier part. Okay, I cannot see it. I saw a question come in about, did you recruit non-English speaking participants? Okay, here it is. Did you recruit non-English speaking participants? If so, how successful was that recruitment, and or were there any lessons learned to share?
So I will say that we did not focus on in recruiting non-Spanish, non-English speaking individuals. Does not mean that they weren't able to be included in it. I hope I'm making sense. And so we did not have any non-English speaking participants in the research study. But what I will say is that we did have partners ready and available to assist us in the event that we did. So again, one of our partners is her first language is Spanish. And so we were prepared for her to actually develop some of the recruitment tools as well for us.
Just a follow up on that one, were your recruitment materials bilingual or was it English only?
So for our research, they were English only. Yes.
Okay, that
Yeah.
helps. And so that may also impact, who
Yeah.
signs up. Absolutely. Or knows to sign up. One other question that came in was talking about being able to discuss about hidden resources when you're talking about doing this type of research with, any type of research, but then again, with a targeted population. So can you talk about hidden resources in the sense of staff or budgetary needs of organizations maybe not necessarily having that or wanting to put focus on it, but the need for it?
So I will be honest, I probably am not the best person to speak to that point. What I will say is that we definitely make every opportunity available where we can to make sure that all resources are available to accommodate for all the populations and people that we are either focusing on or working with. So again, where we don't have the capacity or knowledge or resources, we have partners who do, and that we're going to reach out to make sure that we are either able to get it to the population or we're being able to include them in the next round of decision making for getting more resources for them and making sure that the need is articulated correctly. Yeah.
Love it, Mitchell. If you and Jessica did nothing else, but you both did a lot, nothing else, the word that I'm leaving here with today is partnership. And that is so key in being able to um, impact and affect change. And I don't want to leave out the fact where you talked about, you called it incentive. When we work with people with lived experience, being able to compensate for the time and their expertise, which is an important piece with the research that you did as well. I'm not in full screen mode. Thank y'all so much for taking the time to spend with us on your Friday afternoon. This is being recorded. Again, we'll have the live transcript. If you haven't already subscribed to our YouTube channel, please go ahead. You can also keep up with us on LinkedIn as well. Mitchell, Jessica, again, thank you so much for your time and for sharing this amazing information. Everyone, you all, thank you for your time. Have a wonderful Friday. Be safe.
Thank you all.